Welcome to Dynamic Epithelioscopy and Endothelioscopy, Introduction to the Use of the Corneal Contact Glass. This video course will introduce you to the examination of the outer and inner surfaces with the Eisner contact glass, designed especially for the cornea.
This program is organized as follows. Theory of the contact glass, the use of the corneal contact glass, dynamic epithelioscopy and endothelioscopy.
The theory of the contact glass. What are the reasons for using a contact glass for the examination of specular reflexes? If we examine specular reflections without a contact glass, the view is obstructed by the strong reflection, which occurs at the interface between air and fluid. This tear film reflex makes the specular reflex of the epithelium invisible altogether. This means that the endothelial reflex can be seen only if the interfering tear film reflex has been removed from the field of observation by increasing the illumination angle. This example shows that the anterior reflex disturbs the view. The posterior specular reflex appears only if the anterior reflex has been moved laterally, and then we can make out the endothelial cells. The contact glass is another way to eliminate the tear film reflex. Furthermore, it increases the size of the specular reflexes and increases magnification.
The use of the corneal contact glass. The corneal contact glass has a convex front surface and a flat posterior face. This contact glass eliminates the tear film reflex when the precorneal chamber has been filled with liquid, and so the obstacles of the strong anterior surface reflex is removed anteriorly, far from the field of observation. This is how the contact glass brings out the otherwise invisible specular reflex at the epithelium and improves the visibility of the reflex on the endothelium. For the examination of phenomena by scattered light, a contact glass without colour filter is used. If scattered light must be avoided, the contact glass is equipped with a red filter.
Practical application. Before using the contact glass, its cavity is filled with a viscous lubricant. To start the examination, the light is brought to the center of the contact glass with 3 parameters preset at small values, that is, magnification low, angle of illumination small, width of light slit narrow. For example, for examining the endothelium, we start with a narrow slit and a narrow angle of illumination, and search the focus at the slit at the posterior surface of the cornea. Then, with the angle of illumination increased, we search the specular reflex at the posterior surface. We widen the slit, and finally we increase magnification. Fine adjustments of the illumination angle may be necessary until the endothelium appears, and the polygonal outlines of the endothelial cells can be made out. To repeat, start with small magnification, slit width, angle of illumination. Examine with large magnification, slit width, angle of illumination.
Dynamic epithelioscopy and endothelioscopy. The epithelium. The specular reflex of the epithelium, seen here with a red filter, is present in normal eyes as glistening dots, reflecting spots and plaques, and dark spots, which are all more or less abundant and regularly distributed. Note also the margin of the light slit, the regularity or irregularity of which represents the regularity or irregularity of the epithelial surface. Furthermore, in the same eye and in the same area, when we change the incidence of light, the number of reflecting spots may vary. In this normal cornea, the optical section shows the epithelium as a homogeneous transparent strip between the superficial reflex and the irregular pattern of the stroma. If we widen the slit beam, we recognize the epithelial specular reflex with highly reflecting spots interspersed with dark areas here as well as here.
In this next case, the pattern of the glistening spots is more irregular. In addition, there are numerous and much smaller reflecting dots. And here we see the corresponding phenomena in retroillumination. In this case of chronic fibrinous conjunctivitis, except for a superficial vascular invasion, the cornea looks normal. However, the specular reflex of the epithelium, seen here without a red filter to better recognize scattered light, shows an irregular pattern of grayish units. There are numerous fine, glistening dots scattered in irregular distribution, and seen here at higher magnification, some areas show larger reflecting plaques. In the center of the grayish units, we find whitish spots, which are smaller than the irregular plaques we see here.
More severe changes occur in this case of cicatricial conjunctivitis, with intense stippling of the cornea, which is confined to the interpalpebral area, while the areas covered by the lids are free. When observed with the contact glass without a red filter, we see the stipples appearing like white scales in scattered light, whereas in indirect illumination against red fundus light, they are transparent and produce refraction phenomena indicating surface elevations. A different clinical condition is seen here in chronic damage after prolonged wearing of contact lenses, where we find again numerous small dots in the cornea. When examined with the corneal contact glass, the dots look like white solid bodies of different shapes, shown here in optical section. But in indirect illumination, they are perfectly transparent. The damage does not consist of intraepithelial concrements as one may have supposed, but of tiny cysts filled with semi-transparent fluid.
Endothelium and Descemet's membrane. At the posterior face of the cornea, the optical phenomena are related to the endothelium, to Descemet's membrane, and to retroendothelial processes. The endothelium is seen as a specular reflex pattern here without a contact glass, and usually it serves as the point of reference for examining the posterior surface. This specular reflex on the endothelium without the contact glass appears only in a very small area, an area which is much smaller than the size of the light slit. With the corneal contact glass, the reflex is much larger and actually fills the entire height of the light slit. Note, this is the cornea, and this is an artifact, the reflex at the cornea contact glass. And note the result. The reflecting area becomes very large. Consequently, we can observe the hexagonal cell pattern of the endothelium in a much wider field. And by asking the patient to move his or her eye, we can scan large surfaces. Higher magnification permits the examination of cells in greater detail. In this corneal transplant, the size of the cells is increased, and their shape shows great variations. In some areas, we find cells which appear dark because they do not reflect the light and stand out in relief. Here, for example, we can watch the same cells reflecting at some angles of illumination and casting shadows at other angles, See them here, side by side.
In this eye, damage has been produced by a silicone bubble in the anterior chamber, and we expect this to occur mainly in the superior cornea. And indeed, observed here with a contact glass without a red filter, the cells of the endothelium in the inferior parts appear normal, small and regular. However, when we move to the superior cornea, where the silicone touch has occurred, the cells show irregular sizes and shapes. Another type of damage is shown in this cornea, which has been hit by particles from an explosion. These particles have caused a strictly localized circular endothelial disruption. With the corneal contact glass, we recognize the circular impacts on the endothelium. One day after the event, we still see the lesions here and here. We already observe an attempt at endothelial repair with an elongation of cells and the start of radial alignment here.
Pre-endothelial reflexes. Reflexes in front of the endothelium are related to the anterior and posterior surfaces of Descemet's membrane. Both may hide the endothelium. Anterior Descemet reflex. Here, the endothelium has been veiled by an anterior Descemet reflex. Compare the flat anterior Descemet reflex with the endothelial specular reflex here. The Descemet reflex is weak, but strong enough to obstruct the view on the endothelium, which can be detected just behind the Descemet reflex by slightly adjusting the focus. Posterior Descemet reflex. This next case shows a posterior Descemet reflex in early Descemet's dystrophy, which at first glance appears like an endothelial cell pattern. However, when we change the illumination by slightly tilting the contact glass, this pattern changes drastically. Actually, we see a carpet of small bosses, and whatever illumination angle is chosen, the endothelium remains hidden by the posterior Descemet reflex. In the other eye of the same patient, we find a more severe state of the condition, and the Descemet reflex is more irregular. Compare the two patterns side by side.
Anterior and posterior Descemet reflexes. In this case of dystrophy, we recognize drusen as small reflecting dots here, and here the drusen are seen as interruptions of the endothelial specular reflection. Here the drusen and the endothelial reflexes. And here the drusen in retroillumination. With the contact glass, we see the posterior reflex pattern with its interrupting drusen here, and here the rather flat anterior Descemet reflex. Note how the reflex patterns change with every change of the illumination angle. Here, at high magnification, where the drusen are closely packed, there is little space left for endothelial cells. But if we move towards the periphery, the drusen becomes scarce, and we find more and more endothelial cells. The examination in retroillumination shows a striate pattern at the anterior level of the Descemet reflex, and slightly more posterior, a pattern related to the drusen. Whether the anterior or the posterior patterns predominate depends on where we focus. A combined view is shown here, with the specular reflexes in the centre and a field in retroillumination on the left. And here, the anterior striate pattern on the left is combined with the posterior drusen on the right.
Retroendothelial changes. Retroendothelial changes are signs of anterior chamber pathology. In this case of chronic uveitis, with a gonioscopic mirror, we see large mutton fat precipitates here. Here we see them in retroillumination, and here in optical section. The retroendothelial precipitates, here surrounded by reflexes, seem to disturb the endothelial pattern. But by changing the illumination, we can make out an endothelial cell pattern covering all lesions, which is proof that the posterior protrusions are indeed retroendothelial phenomena. Here we see an unstable anterior chamber implant. The endothelial cell pattern is interspersed with strongly reflecting speckles. Here seen side by side with retroillumination. These glistening speckles are related to the light-absorbing phenomena in retroillumination. As seen here at the margin of the illuminated field, in specular reflection. The glistening speckles seen in specular reflection are caused by pigment, which can be recognized here in retroillumination. If we change the illumination angles constantly, we can distinguish between pre- and retroendothelial phenomena, as seen here in a pseudoexfoliation syndrome with drusen. Here we might presume a defect in the endothelial layer, but just a slight change of illumination proves the endothelium to be intact. Some of the large bosses actually are not drusen but retroendothelial phenomena.
Lesions of Descemet's membrane. Lesions of Descemet's membrane are easy to discover when the margins are bulging, as here, in this case of congenital glaucoma. The curled borders form crests, which act as cylindrical lenses. With the contact glass, we observe the pre-endothelial reflex as being flat, even in front of the crests. Between the crests, we can make out the faint contours of endothelial cells, covering even the area of the previous rupture. In this case of keratoconus, we find a rupture of Descemet's membrane with a detached lamella. The rupture is seen here with the contact glass in retroillumination, with the detached lamella here scanned with the narrow slit. In specular reflection, we recognize the endothelial cell pattern extending also into the area of the rupture. And even the detached lamella has been invaded and is now covered by a carpet of endothelial cells.
Surgical damage may be difficult to detect, such as here after an attempt to remove vitreous from the wound. We see just a faint line in retroillumination, which is the border of a defect in Descemet's membrane. This border is made visible only by very careful focusing, because no crests have been formed. Easier to recognize is the damage here caused by a cyclodialysis spatula. The detached Descemet's membrane has formed a flap, which has a glass-like appearance in retroillumination and light-conducting properties. In contrast, the margins of the still attached flat Descemet's membrane are very difficult to bring into focus, but can be recognized in retroillumination. This is the end of dynamic epithelioscopy and endothelioscopy Introduction to the Use of the Corneal Contact Glass. It is part of a series of instructional videos devoted to the biomicroscopy of the eye. Welcome to the examination of the chamber angle with the slit lamp. Introduction to the use of gonioscopic contact glasses. The purpose of this program is to familiarize you with the refinements of the examination of the chamber angle.
To reach this goal, our video program is organized as follows. Slit lamp examination techniques, specifically adapted for the chamber angle. Topographical landmarks, in which we will show how to find our way in the anatomy of the chamber angle. Detail analysis, in which methods are shown for detecting minute changes in the tissue.
Examination techniques. An exact examination of the chamber angle requires the aid of auxiliary optical devices. This is because the optical rays deriving from the angle are totally reflected at the interface between tear film and outside air. The way to eliminate this total reflection is by using contact glasses which alter the shape of the tear film air interface. And to direct the rays towards the observer, these contact glasses need mirrors. The different models of gonio contact glasses vary depending on the position and consequently the inclinations of their mirrors. In gonioscopes, the end of the mirror cuts the corneal contact zone. That is, gonioscopes have an epicorneal mirror. In the three-mirror contact glass, the entire zone of corneal contact is free, and the angle mirror ends at the limbus. In gonioscopes with an epicorneal mirror, the view is tangential to the cornea and may reach the angle even in case of a narrow chamber angle. With the limbal mirror, the view is tangential to the iris. And in a flat anterior chamber, the view to the angle is blocked. Therefore, contact glasses with an epicorneal mirror may be called narrow-angle gonioscopes, and those with a limbal mirror may be called wide-angle gonioscopes.
A wide-angle gonioscope can be turned into a narrow-angle gonioscope if it is shifted along the eye until its mirror assumes an epicorneal position. However, there are cases where the application of a contact glass is clinically obsolete. And here, tear prism gonioscopy is an alternative. In this case of corneal ulcers, otherwise invisible white cell deposits can be detected by shifting the tear meniscus to the lower angle, whereby the tear fluid, if necessary, with an addition of viscous eye drops, is used as a prism. Another example is this case of sarcoidosis, where a barely visible hypopyon appears in its full extent by the tear film prism. And in this next case of blunt trauma, the tear prism reveals otherwise invisible hyphemia. Another non-contact access to the angle is lateral limboscopy. Here we obtain an outside view on Schwalbe's line in a posterior embryotoxon. We can examine the embryotoxon in direct light and in indirect illumination, whereby its glass rod properties become apparent.
Topographical landmarks. This is a schematic view of the chamber angle through a mirror contact glass. where we see the landmarks for clinical descriptions. Schwalbe's line, the trabecular meshwork in the area of Schlemm's canal, the scleral spur, the ciliary body band. Here we see the landmarks in the natural gonioscopic view. Schwalbe's line, barely visible here, the trabecular meshwork in the area of Schlemm's canal, the scleral spur, the ciliary body band. Now we scan the circumference laterally, and when we arrive at the bottom, the angle becomes wider and wider. When scanning, bear in mind that the lower nasal angle is a typical location for rudimentary coloboma. This suspicion is confirmed here by examining the second eye of the same patient, where we see the same widening of the lower angle. Detail analysis. In this chapter, we will show techniques of illumination, the evaluation of angle widths, various types of pigmentation, developmental anomalies.
Techniques of illumination. Basically, the same rules of illumination apply as for the other parts of the eye, with regard to direct illumination and indirect illumination. In this angle, the wide slit light reveals little structural detail. But if we narrow the slit, we start recognizing fine tissue strands here and here, because we avoid the interference of illumination modes. If we want to take advantage of this technique for a wider field, we tilt the slit horizontally and then recognize the mass of fine strands with which the angle is filled. If we turn back the slit vertically, we now can follow single strands. This strand is invisible in the field, where direct and indirect light coincide and thus interfere, but can be recognized when observed against a non-illuminated background. If we analyze the strands more thoroughly, this strand has a brown color in direct light, while here again it is invisible.
Here, other lightly pigmented strands appear dark against a bright background, due to absorption phenomena. But they are also transparent, as revealed by refraction phenomena. Here against a dark background, and here against a bright background. The narrow light slit, furthermore, is essential for observing the correct color of pigments. Here with a wide light beam, the pigment appears black because the backlight showing it as an absorption phenomenon interferes with the direct illumination. But when separating the backlight from the direct illumination, we can now see the true red-brown color of the pigment. Evaluation of angle width. For the evaluation of a wide angle, a narrow angle, or an occluded angle, one criterion is the visibility of the angle anatomy. That is, whether we can reach Schwalbe's line, Schlemm's area, the scleral spur, the ciliary body band. The second criterion is the shape of the narrow slit light, whereby we evaluate its continuity in length and a continuous change in width.
In case of an open angle, all anatomical parts are visible, and the light slit is continuous in length and width. In case of an occluded angle, some parts of the anatomy have become invisible, while the light slit remains continuous. And in case of a narrow angle, parts of the anatomy are invisible, but the light slit is discontinuous in length, as well as in width. This is easily detectable when examining at an oblique angle of illumination. However, when examining at very narrow illumination angles, the discontinuity in length can be difficult to detect. But then, with a slightly wider slit, the discontinuity in width still offers a reliable sign.
Problems with lateral limboscopy. Here we examine a narrow angle in lateral limboscopy. In the center, the anterior chamber is moderately deep. But when we approach the lateral limbus with the light slit, the angle appears nearly obliterated. When we compare the width of the chamber laterally and at the lower circumference, we note that it appears deeper in its lower parts than laterally. This phenomenon, however, represents no anatomical fact. Bear in mind that in the lower and upper circumference, due to the extension of the non-transparent limbus, the light slit is just not visible up to the very angle.
Problems with 3-mirror contact glasses. When using the 3-mirror contact glass with a limbal mirror, we see the slit light discontinuous and the anatomy of the angle is invisible. When slightly shifting the contact glass, the discontinuity of the light slit decreases and we obtain a view on Schlemm's area in the trabeculum. Note again the discontinuity of the slit as a sign of obstructed view into the angle, and the decrease of the discontinuity when the access to the angle has improved. If, instead, we use a gonioscope with an epicorneal mirror, there is still a discontinuity of the light slit showing the narrowness of the angle, but the view now reaches up to the ciliary body band.
Always bear in mind that the contact glass may induce errors of judgment caused by artificial deformations of the angle. Here the artifact is obvious due to the conspicuous corneal folds. But here the deformation is detectable only by comparing the normal corneal curvature with the slightly unnatural curve of the cornea. Just compare the normal concave curve and the abnormal slightly convex curve side by side.
Accumulation of pigment. Pigment accumulation in the anterior chamber may be found within the trabecular meshwork as endotrabecular pigment, at the surface of the trabeculum as epitrabecular pigment, and scattered all over as deposits at the bottom of the angle. Endotrabecular pigment appears hazy because it is veiled by the overlying meshwork, and thus it can be recognized only when occurring in large patches. Superficial pigment, in contrast, has saturated colours and sharp boundaries, and even small granules are seen distinctly.
Endotrabecular pigment forms patches within the meshwork in the area of Schlemm's canal. Epitrabecular pigment may also accumulate in Schlemm's area, and often has a superficial relief, which can be made out in optical section. Furthermore, superficial pigment may accumulate at the meshwork adjacent to Schwalbe's ring. In contrast, deposits at the bottom do not respect anatomical boundaries and may spread over the scleral spur as well as over the ciliary body band and the iris root. The topical distribution around the circumference of the angle, as a general rule, shows a maximum pigmentation at the bottom and a decrease in the other parts. Note, any deviation from this rule, as for example here with a maximal accumulation laterally, is suspicious of pathology, as here in case of lesions after blunt trauma.
This case of pseudo-exfoliation syndrome may serve as another clinical example. In the upper circumference, Schlemm's area shows endopigmentation, and this is the only pigmented part here, while Schwalbe's line and the scleral spur are free. Laterally, a second pigmented band appears, confined to Schwalbe's line, deep black and with a sharp contour. At the bottom, we find even more pigment, at Schlemm's area, at Schwalbe's line, and in addition, a third pigmented band in front of them. Here we see the endopigmentation in more detail, with its typical unsaturated brown colour and with hazy contours, which, when found in the upper angle, is a good indication of pseudo-exfoliation syndrome. When moving laterally, Schwalbe's line becomes more and more pigmented and we can recognise single granules. And when approaching the bottom, we observe the third pigmented zone in front of Schwalbe's line, the so-called Sampaolesi's line, which is diagnostic of pseudo-exfoliation syndrome. Its position anterior to Schwalbe's line can be verified in optical section. When we follow the light slit on the outer and inner corneal surface, we see them coming together at Schwalbe's line, that is, behind Sampaolesi's line. Compare these outer and inner light slits in pseudo-exfoliation syndrome with those in this case of excessive pigmentation where they meet at Schwalbe's line in front of the pigment.
Tissue strands. Tissue strands covering the angle may derive from the ciliary body band and from the iris root. Embryonic remnants. In this normal eye, embryonic remnants form strands deriving from the ciliary body band, which merge with iris processes, ending mainly in the ciliary body band, but also reaching up to Schlemm's area. In this case of microphthalmos, but an otherwise normal eye, on the other hand, strands are confined to the ciliary body band, while the scleral spur, as well as Schlemm's area, are free. Just here, a few isolated iris processes are protruding. This case of congenital glaucoma looks normal at first glance. However, when looking more closely, we find tissue strands extending far up the trabeculum. And here are extremely fine cobwebs, extending even further over Schwalbe's line into the cornea, and this can be made out more clearly when observed in retroillumination against a narrow light slit. Goniotomy was performed in early childhood, seen here, and this allows the parts of the angle behind the antepositioned iris root to come in contact with the anterior chamber. Compare the goniotomy with a free Schlemm's area here, and here the untouched area where tissue remnants extend over Schlemm's canal, and here side by side. Later, during the examination, Schlemm's canal has been filled with blood, and this allows us to recognize its position even better and to follow it into the goniotomy area.
If the covering tissue is transparent, it is obviously more difficult to detect, as in this next case of congenital glaucoma. Here, the angle appears narrow, but otherwise inconspicuous at first glance. Here, however, the angle opens up. The ciliary body band becomes wide, and here we find unusual lacunae at the iris root. These lacunae look like holes in a hazy covering layer, and indeed, in the lower angle, such a covering layer can be made out as a radial striation, where we can find a contrasting dark background, offered here by Schlemm's canal filled with blood. And in the lateral angle, this transparent layer can be seen by its circumferential striation.
In this case of embryotoxin posterius, we can suspect a covering tissue layer, although no such tissue can be seen. The suspicion arises because the narrow slit light shows the iris root being affixed directly to the scleral part of the ciliary body band. There is pathological tissue obstructing the view on the scleral spur, which has prevented the free unfolding of the ciliary body band. Synechiae. Synechiae do not respect anatomical boundaries, as shown here encased years after post-surgical loss of the anterior chamber. The adherence of the iris stroma is not confined to the angle, but extends far into the cornea. Note that only the very superficial tissue is adherent. The stromal pattern has remained normal without any distortion, and this is a picture indicating a mechanical cause for the synechia. In contrast, in this large synechia, caused by sarcoidosis, a pigmented adhesive zone points to an involvement of deep iris tissue, and thus to an inflammatory cause. Here we see synechiae in the making, in a case of subchronic iritis. There are many grayish, small fibrin strands between the iris root and the scleral spur, which we recognize best at the margin of the light slit against a dark background. Here is a larger fibrin strand, extending even to the stroma of the iris. And here again, a smaller one.
In this other case of sarcoidosis, the oblique distortion of the iris adhesions points to their inflammatory origin. And in this case of chronic iridocyclitis, the post-inflammatory nature of the adhesions is indicated by the chaotic directions of the tissue strands. Compare the inflammatory with the mechanically induced synechia.
This is the end of the examination of the chamber angle with the slit lamp. Introduction to the use of gonioscopic contact glasses. It is part of a series of instructional videos devoted to the biomicroscopy of the eye.